thank you again for having me. What a pleasure to be here in this beautiful country, in this beautiful state. I'm going to go out from the medical home a little bit broader to the networks, so thinking about PHNs, practice-based research networks, the population health analytics, and how we can link our data for quality, and just really kind of show you some examples of what we're doing in Oregon and across the country. And of course, many questions that were asked, hopefully I can address those, but if you have additional questions at the end, we'd love to answer those, or at least have a great conversation, because I think, as Kevin said, the questions were brilliant, and I don't think any of us have the answers, but it's really fun to have the conversation, especially across countries. So a quick little bit about me. I'm a family physician, always had an interest in healthcare policy. I think there was a question over here about the curriculum. We have a lot of students coming in very interested in policy, very interested in global health. What better career is there than general practice, primary care, to really address those? So that's what drew me. I went to Harvard Medical School. There's no family medicine department at Harvard still to this day, but I was very interested in policy. I felt like family physicians saw all members of the population cradle to grave through all aspects of life, and so we are the experts in what the population needs as far as health. And I was also interested in global health, so I spent quite a lot of time in Africa and was also over here in Australia studying your policies. So that's one of the pieces I think where we haven't traditionally identified those students that are interested in public health, population health, global health, and health policy, and really brought them into primary care. So that's one of my goals that I've really pushed to, and the equity as well. Students coming in are really very concerned about disparities, very concerned about vulnerable populations. So that was me. So I was at an orphan school with no family medicine department, but yet still went into family medicine because of my interest in health policy. I was here. I did graduate school in England because as a 24-year-old in the U.S. healthcare system, I began to wonder, when all of those gurus were telling me, we have the best healthcare system in the world, but yet I was looking at all of the poverty around me and the ill health and thought, well, maybe England has it figured out, maybe Australia has it figured out, maybe South Africa has it figured out. So I went around the world and had a remarkable time studying different healthcare systems. I also grew up in a rural state, Montana, which is up on the northern border between the U.S. and Canada. So that also allowed me to see the need for primary care, especially in rural areas. And I know someone over here was talking about the need for rural areas and perhaps some different models there. I'm now a researcher. I got very interested in health policy and health policy research and the intersection between research and data, information, and then how to translate that both into practice change as well as policy change. I was recently elected into the Institute of Medicine, which has just recently been changed to the National Academy of Medicine. Some of you may know it as the IOM. And I'm, as mentioned, the president of the North American Primary Care Research Group. So I've had some really wonderful honors bestowed upon me in the last year or two. So hopefully I'll live up to filling the big shoes of Kevin and others who have been in the IOM for quite some time. This is the healthcare system that I practice, and it might look quite a lot like yours, but just to give you a brief thumbnail sketch of the U.S. healthcare system. So here's where we are. The goals, as I mentioned, I'd like to describe networks of patient-centered medical homes, so getting out from the home, and how our networks of PCMHs, or whatever you want to call them here, can serve as data hubs and real-world community laboratories. I'll present some examples of work that we're doing in a thriving community laboratory we have at a very unique organization called OCHIN, and really just discuss and have conversations with you all about regional data sharing initiatives and how those can have a really great impact on patient care and population health. So we talked about the patient-centered medical home. We talked about the neighborhood of services around that. What we found is there's also a need for a patient-centered medical village. And the village is multiple patient-centered medical homes all coming together and sharing resources. So I think there is some overlap with how the practice networks were designed here, or some new functions that they could serve. So our vision of the village is shared IT support, data sharing, those practice coaches, the flow of knowledge, learning collaboratives, where different homes don't have to recreate the same wheel from GP practice to GP practice to GP practice, but collaboratively can really come together to share IT, to share data resources, to share best practices. And then we have also this concept of a village champion. So you really need the clinician champions and the leaders at the individual practices, but then the village champions are those pollinators that say, hey, we figured it out over here, we'll mentor you in this area, well, you figured this out, why don't you come mentor us? and cross around the village. What we're seeing in the US is there's a lot of movement towards integrated systems. So you have a patient-centered medical home, it's integrated with the specialty, the hospital, other services. But the primary care folks are somewhat isolated and saying, wait a minute, the EHR doesn't really serve our needs. We don't really know how to benchmark ourselves against what other practices with similar populations look like. So there's also this need for horizontal integration and sharing. And that's really why we developed the concept of the patient-centered medical village. Patient-centered medical villages can also serve as practice-based research networks or community laboratories. So that's what I've begun to start. I use very different language out in the community. We don't use the R word, research. We talk about improvement and data sharing. But when I go back to the medical campus, where there's a lot of folks in high-tech science and biomedical research and getting billions of dollars from our National Institute of Health, we're beginning to talk about primary care laboratories and community laboratories and the important infrastructure that we need, and the unique point in history where we actually have much of that infrastructure now with data and information technology and engagement and working together in these collaboratives. So a community laboratory. Who has time for research, right? We're all spending all of our time entering data into our computers. So in this picture, that's our new clinical integration engine. So of course, hours of data now with electronic health records, putting data here, putting data there, ticking boxes here, ticking boxes there. But wait a minute, did you just say data or data, depending upon how you pronounce it? So again, very wonderful point in history where we can now aggregate data like we've never had before. Big data, giant data, huge data, whatever you call it. It has the power to improve our practices and our population's health. Of course, there are several steps to getting there, and it is a journey, as Kevin said, but it's really exciting and a really exciting time to really, I think, reinvent ourselves, get that student who's really interested in information technology, who's really interested in the epidemiology and looking at this information and using that information to create new knowledge and to transform practices and improve health. So we all work in community laboratories. I do have a video here, which I'm going to try to show at the moment, and my tech skills are very limited. But the history behind this was I was recently, again, elected into the Institute of Medicine, which is quite an honor in the United States. There's only about 1,500 members across medicine in all areas of medicine. And so there's only 5 people from the state of Oregon, or from my campus, and only 9 people from the state of Oregon in the IOM. So the folks on our campus wanted to produce publicity about it and brag about it. So they called me up and they said, we want to come to your laboratory and film your team working on your science because we understand that you do science. And I said, all right, well, usually it's my backpack that I carry around from community health center to community health centers and from all these other places where I work. So you probably want something more glamorous than my backpack. So why don't you come to my primary care clinic and film me there? So this was a video that they made.
Patients struggling to gain access to basic care. Medications, information, a hospital service that many of us would take for granted. So we need to start thinking about other ways to intervene as advocates, to change policies, as innovators, to change our practices, to become more patient and family-centered, and then as well as partners with our patients and our teams one-on-one, identifying individual needs and then helping to meet those needs. My election to the Institute of Medicine was a great surprise and a huge honor, largely due to the fact that I'm trying to do things a little differently than some folks have traditionally done in biomedical research. Moving towards teams, we're using data from our electronic health record to identify patients that may be at risk or may need some assistance with care management. We have care managers working with that data. You need a team to take care of a patient. You need a team to do a research study. You need a team to think about how to translate what you're finding and disseminate that information to many different audiences. And so nobody can do this alone.
So the other reason I show that is because then you get to see my beautiful children who are here with me in Australia at the moment, probably over at the zoo. So again, we've just been thinking about how do we talk in this different language depending upon the audience. And so it's really important to talk about the need for the laboratories, the science, the study of the data that we have, and the resources to do that. I don't need a microscope, I don't need a really expensive basic science lab, but I need the IT infrastructure, the engagement, the longitudinal team to be able to take care of the patients and also do the research that's really, really important to us in figuring out what's working and what's not working. So the Ocean Practice-Based Research Network, or PBRN. So Ocean is a very unique organization. Again, one way to describe it is a patient-centered medical village. It's a nonprofit community health information technology network, which was started in 2001, originally in Oregon only, so the Oregon Community Health Information Network. We're now serving practices in over 18 states, so our name is now Ocean, shortened, so no longer tied to Oregon. The way that this collaborative works is community health centers, GP practices around the country come to us and say, we want to join this collaborative. And what they get is a linked electronic health record for this large network of primary patient-centered medical homes. There's one master patient index across multiple states. So that we are the linked electronic health record. We serve as the host. So if a patient walks into any one of our practices, so we have a migrant farm worker population, as you mentioned, that moves from Oregon down to California, back up to Oregon. They walk into any one of our practices. It's the same record that the GP pulls up. It's all that information. And there's over 300 primary care sites now that are part of the OCHA network with 3,500 providers, mostly community health centers serving disadvantaged low-income populations, but also rural health centers, school-based health centers. Some of our prison system health is on it as well. So we now have about 1 million distinct patients. Those are patients that have been seen and impaneled in these practices over the last 3 years, and over 15 million visits. So it provides a really nice point of care tool to treat the patients, but also very helpful for looking at population health and doing research. So another way to think about it is a 21st century PBRN. The 20th century PBRNs were doing really amazing research, and doctors carried around index cards where they wrote observations and information in between visits, and researchers collected that. Now we can go to the electronic health record and begin to start aggregating that data and studying it. So it's really exciting. Again, here's where we are located. And as I mentioned, we are not generalizable to the US population, but we have a very representative sample of underserved patients, racial, ethnic minorities. A good percentage of our patients speak Spanish as their primary language, not English. Almost 50% live below the federal poverty level, and almost all of our patients are below about 200% of the federal poverty level. 25% are uninsured, which I know is a foreign concept here. Don't ever go down that road. Keep insurance for everyone, but we still in the US have quite a lot of patients uninsured, even after Obamacare. And over 50% of ours are insured by Medicaid, the state-based program, and or Medicare, the federal insurance program. So when we first launched this research network at Ocean about 5 years ago, we really wanted to hit the sweet spot between practice transformation and research. We felt like there was a huge need for doing practice transformation, getting those practice coaches out there, redesigning workflows, getting IT support, working towards becoming a patient-centered medical home. But we also saw the need and the very unique resources we had to do research that would be relevant at the national level for changing policy and practice. So the more that we could bring those circles together, that's really where we see the community laboratory that we're building. And our hoping and our vision and some of our reality is it's becoming quite a powerful network to do that. So just a few examples of bringing the data together. Again, going from the GP practice level to this more meso network level. We've done quite a bit with data aggregation for practice transformation, care coordination, and panel management. Researchers, IT folks, clinicians have really all come together to say, okay, now that we have the electronic health records, we want to get the data out, we want to use it in real time, on the ground, and in the real world. So our company is a nonprofit company that works with the electronic health record, but is also developing population health analytics. And what we have is a suite of tools called a CureA, which is bringing the data together in near real time. So essentially it's less than 24 hours old. So if you want to look at your panel of patients, it's up-to-date data. It's not data from like 3 months ago or 6 months ago, which used to be the case when the only thing we had was health insurance company data. I can't tell you how many pieces of paper I've gotten in my mailbox over the last 15 years of insurance companies telling me about my quality. You didn't get Mrs. Smith her Pneumovax. You didn't get Mr. Smith his hemoglobin A1C laboratory test done on time. And so what a great time that I don't have to have insurance companies telling me about my poor quality. I can have my electronic health record telling me about my poor quality, and I can act on that in real time and improve that quality and get the team together to think about innovative solutions. So this software brings together the electronic health record data claims data, community data, to really do the analytics and the healthcare intelligence that we need and now have the ability to do in today's world. It's an interactive tool. It's got different displays, and I'll just show a few screenshots. You probably have similar systems, or you're working on similar systems in your clinics, and I apologize, it's a bit small. But this is really just looking at, you can say, hey, I want to look at my practice over the last year and how they're doing on, this one is chronic stable coronary artery disease lipid control, and then I want to look at how my practice compares to other practices, and are we going up and down, do we look like we're kind of in the same range? Here's one that is at the provider level, looking at different diabetes markers over time compared to all the providers in the practice and then all the providers in the network. This also develops patient rosters so that as a provider, and this is my colleague John Munch, he can go in there and say, I want to look at all the patients that are assigned to me. These are his diabetic patients, and then there's a whole number of indicators. Are they on medications to reduce their blood pressure? Have they had their blood pressure checked? Is it high? If it's high, it's in the red zone there, et cetera. It also produces scrub lists, so for each day that your patients are coming in, it'll say, these are all the patients that are scheduled to see you today. Hey team, what are the things that they need that we can try to work on getting for them? And it facilitates what are called huddles, where the team comes together and says, hey, we've got these 20 patients coming in today. Even though they have issues that they're going to want to address, what are some of the things that we can maybe help them today, get them up to date on immunizations and other tests that they need? So that's one of the ways that we're using the data, and it's really exciting. And having those kinds of tools, there's no way that an individual practice, in my opinion, can build those tools on their own, nor should they. It should be the village, it should be the network that helps numbers of practices pull that data together and begin to understand it. We have this situation where there's hundreds of electronic health records in the US and none of them talk to each other, so this issue of interoperability is challenging. What this type of software does or promises to do is ingest data from multiple different electronic health records and make sense of it. So we've got about 10 major ones that we have brought together in this system. The data aggregation for research about practices in our network. So in the Patient-Centered Medical Village, one of the first studies we did was we looked at a cohort of diabetics across 23 clinics, and we identified significant variability in the quality of care being provided. And we're now studying best practices that can be disseminated. So in 23 practices, all serving low-income patients and populations, these are the diabetics who had gotten one of their lipid tests done. There was one practice where only about 10% of indicated patients had this test done. And on the other hand, there was another practice where about 90% did. So significant variability here. Here's flu shots that had been done, kidney screening, and then the glycosylated hemoglobin. So rather than say, who are these people? Let's go punish them. We said, who are these people up here? What if they got figured out that we could study and learn and maybe send our practice coaches down here or enroll them to be mentors and coaches for their colleagues? Then we also discovered, and there was a question here about how do you risk adjust? How do you adjust for all the social vulnerabilities of the patients? Maybe the practice that was doing the worst, maybe all of their patients were uninsured. Maybe none of their patients spoke English. Maybe they didn't have the ability to get what they needed or understand that they needed it. So we discovered that the variability in the quality of this diabetes care was highly correlated with the clinic's patient panel characteristics. And we began to look at data, and again, brought in PhD biostatisticians who understood much more about how to use this data and make sense of it than I do. But one of the things which I'm very passionate about, many of us are, is the impact of insurance. And so it turned out that one of the main drivers for why a clinic was doing poorly was that fewer of their patients on their panel had insurance or continuous insurance. We also saw for some of them that patients with that were from minority ethnic or racial groups, that was also contributing to the clinic's scoring, poor quality. So how do we get at, your clinic's doing great, but wait, you have all the affluent patients in your clinic's doing poorly, you have all the vulnerable patients. Well, we can begin to understand this is what that patient population looks like, and then you could almost go back and create a completely different grid here, adjusting for those, which we're beginning to try to work out a system for doing that. There's a lot of debate in the US right now because folks say if you adjust, you'll just have an excuse to continue providing poor quality care to poor people. On the other hand, if you don't adjust, the clinic's going to start dropping those people if they're getting paid for performance. So how do you meet in the middle so that you're providing high quality care, but you're also giving the clinic additional resources or somehow giving them what they need to not burn out, as Kevin said, from having these patients with the social vulnerabilities, and also go bankrupt because all of a sudden their performance looks so poor that they're not getting their incentive payments that they need. So this is where we need the scientists in the laboratory studying how do we do this, how do we do it in a way that's statistically robust and accounts for what we need to do. Another thing that we did with our data is we've had in the United States what's called the Children's Health Insurance Program, or CHIP, for almost 20 years now. And so people were saying, and I have another video because I study uninsured children, I have another video where I talked about people in the United States think there's no uninsured children because of CHIP. And so this also enabled us to say, wait a minute, we're going to pull data together from across this network. So we have just under 185,000 children in this sample. Big, big sample. We found, well, gosh, actually 1 in 5 children were uninsured when they showed up to one of our community health centers. And then among those that were uninsured, about half of them remained uninsured for 2 years at all their subsequent visits. So, gosh, there are uninsured children out there, and we know that. They're coming into our clinics. So we've begun to build tools in our electronic health record to help our teams address that social determinant of health and get information to those families about the availability of insurance and try to help them enroll. We also have this silly thing in the United States where you have to enroll in Medicaid, and then a year later you have to re-enroll and fill out all the paperwork again, and a year later you have to re-enroll. So don't go down that path either. So kids, they get insured, and then a year later they're uninsured. So another thing that we're doing is bringing this data together. Again, if you're in across the state or a region, or in our case nationally, assessing policy natural experiments. In Oregon, we had a very interesting natural experiment. Again, we have this sad situation where not everybody's covered and the state couldn't afford to cover everybody. So in 2008, Oregon wanted to do something that would make it fair, and they said, well, for folks that don't automatically qualify for Medicaid, we're going to have a lottery. We're going to have everyone sign up who's interested in gaining insurance, and then we're going to randomly pick folks that can apply. So what we did with our data is we looked at how utilization of primary care services changed after the Oregon randomized Medicaid expansions. And so what happened was the utilization went up, and I'll explain these groups because that's the other nice thing about having the data and the resources. The utilization went up, and it stayed up for those that maintained insurance coverage, and then those that lost, it went back down. But so a lot of people studied just the group that gained coverage. So there's 4 groups here. One, these were patients that were continuously uninsured throughout the whole study. So that was one of our controls. They did not ever gain coverage. This gray line was folks that had been insured continuously throughout the study. So they utilized care at a much higher rate, which is what we see in the US. If you're uninsured, you're not using care. If you're insured, you're able to access it more readily. Then we had this group where they gained coverage, and there was this group here in the yellow that lost coverage after about 6 months, and you see their utilization went down, and then the group that maintained was up here. But a lot of people just studied this experiment for about 6 months, and they said, oh my gosh, we give people coverage and their utilization goes through the roof. They're going to cost us a whole lot more. They're going to come in the emergency departments more, which was a big study published in Science. They're going to bankrupt us. What they weren't able to do, and what we were able to do, was say, well, most of them lost it and went back down. And actually, they kind of settled out to where everybody else was with insurance. It wasn't like they just came down and beat down the doors and used every bit of health care that was available over time. So we've been really fortunate to have our laboratory and these control groups, and in this case it was a randomized experiment, so it gave us a little bit more ability to say we kind of know what happens when people in the US get coverage, and they probably do need it because the primary care services are important, and we'd like to see them accessing those at a rate that's comparable to everyone else in the population. So the next big natural experiment that our team has embarked on studying is Obamacare, and what Obamacare did in addition to the gazillions of other regulations and laws that were implemented, one of the big and very controversial federal moves was to say all states are going to expand their Medicaid program. And then it went to the US Supreme Court, and the US Supreme Court said, well, actually, it's unconstitutional because of the divide between federal and state. You might know a little bit about that here in Australia. So states can choose. Even though the federal government's giving them billions of dollars to expand their Medicaid program, many have decided, no thank you, Obama, no thank you. We're not going to expand our Medicaid program. We don't want our poor people to have health insurance coverage. So we've got about half of our states, or now a little more, that are expanding, and the other half that are not. So in our network, 5 expansion states, California, Minnesota, Ohio, Oregon, Washington, and 4 non-expansion states are providing us with an interesting natural experiment to see what's happening to our patients in states that expanded Medicaid and what's happening to those that are not. So we're just beginning. We're just embarking on this study. One of the things about being a researcher, and it may be the same in Australia, is it takes several years to get funding to do some of this work. So we're working on getting a little more timely and relevant to when our policymakers and our practices need it. But we've just now gotten funding from National Institute of Health and our Centers for Disease Control to do more. But in our first year, we were able to compare patients in expansion states versus those in non-expansion states and just get a sense of how their visits changed and their insurance at a visit changed. So the year before Medicaid expansions in the expansion states compared to a year after, and then compared to the non-expansion states. So states expanding Medicaid in our centers, we saw patients coming in uninsured, a 47% decrease, and patients coming in with new Medicaid insurance, 46% increase. So patients in those states were getting coverage. They were coming in. 41% increase in receipt of preventive care, 23% in limited services, and those are services that don't require a physician visit, but services with a nurse, such as immunizations or lab draws and lab tests and sometimes x-ray, et cetera. And then new patients, we saw a 14% increase in new patients seen. In the non-expansion states, we did see some changes, but they were fewer and more muted. They had about a 20% decrease in the uninsured and only about 12% increase in Medicaid. And that can be explained by some of the other health insurance programs like marketplaces that have been made available for individuals to go and buy coverage. And also that there was just more awareness about Medicaid, so people that might have qualified under the old rules may have come forward in those states, even though there wasn't an expansion, and they actually qualified under the old rules, so they gained it. And this is just showing the data in a slightly different way, but again, here's those expansion states with this huge drop in uninsured as compared to a slower, smaller drop in the non-expansion states, and then the Medicaid, they're way up here. We didn't see a lot of change in the private insurance, but most of our patients, again, are either uninsured or publicly insured, so we don't have a lot of folks in that group in our network. So then we get to, and again, this wonderful question here, wow, we're really excited, we've got all this data together, we're transforming the system, and the World Health Organization tells us that the impact on equity and health and well-being, these are all the factors. So we're still right down here in this tiny little box, improving our health system. What about all of this? How do we address that? What do we do? And so we kind of scratch our head, and after patting ourselves on the back, we were humbled and embarked on, all right, let's see, what can we do next? So we have a new organization in the US called the Patient-Centered Outcomes Research Institute, or much easier, PCORI. And that was an organization created through Obamacare to think about doing patient-engaged research, patient-centered research, comparative effectiveness research, and thinking about things differently. So one of their huge initiatives has been developing a national network called PCORNet to bring together huge amounts of clinical data. And then our approach was, hey, we'll do that, and we'd love your funding because we have our clinical data from these community health centers put together, but we'd also like to think about bringing other data sets together. So with PCORI funding, we've got OCHA in our network, plus another similar size network out of Florida, and then Fenway, a smaller group out of Boston. And we said, all right, our network is going to have all the patients that are enrolled or being seen at those centers. Then what we'd actually like to do is bring in their hospital data, their insurance claims data, and most importantly, we'd like to understand the context of the communities within which they live and bring in that community data and put all that together. And it's been a really exciting journey. Again, we had 18 months to do all of this in the first wave, and now we're beginning to think, okay, now what do we do with all this data? But I'll show you a few examples. So what we're doing is, once we've gotten this data aggregated, just thinking about creative ways to strengthen partnerships between the healthcare, the primary healthcare, the social services, public health. But we're just starting. One study we did, thinking about the population level, is you can build geospatial tools aggregating clinical and community data, and in this case, to help primary care better partner with community organizations. And I know Australia is far ahead in this regard. I've had colleagues come over here and say, oh, you're doing all this cool stuff, we want to emulate it. So we said, we're going to take, myself as the children's health insurance researcher, I said, I know about this insurance status of all these kids in the practices. I'm going to geocode that and figure out for practices, where do their uninsured kids live? And then overlay that on the income to say, those are uninsured kids in income zones which really likely qualify for this coverage. And so try to give practices a sense of, here's where all your diabetics who are out of control live. Wow, there's a YMCA right in that neighborhood. Can you partner with them? Here's where all your uninsured kids live. Wow, there's now these grants coming out of the US government to send outreach workers out to get families insured. Can you work and partner with those organizations? So just starting out, but that was in my area with the Children's Health Insurance, one way to do it. But you could do this with any clinical data that you have. So we're just starting to think about doing that with much of our other data. At the population level, we have a lot of folks talking about public health has done this for decades. Public health has the data. They're doing really great surveys. They've got epidemiologic surveys. They've got surveillance going on for infectious disease and chronic disease. But many of our public health researchers come to me and they say, we just need the clinical data. And then we've got the clinical data system sitting over here saying, well, we don't really have the public health data. We don't really understand the communities. So there's an organization in the US, it's actually under the Health and Human Services, the National Committee on Vital Health Statistics, that some of our leading family physicians have served on. And they've really come up with, how can we bring this clinical big data and share it with our communities to support population health? So they've come up with this concept of the community as a learning system, using local data and bringing our clinical data to that. And then the community as a learning system, again, those of us in academic institutions down here, we're not as important as we think we are, but we're certainly important in contributing to this amazing data that communities can now pull together. But thinking about how do we use that to improve community health. So we're in that space. And then at the individual level, so bringing our data into the community level, but then at the individual level back to that that clinic or wherever you're interacting between your healthcare team and your patient. Maybe it's a televisit or a face-to-face visit. But we've also been working on the concept of a community vital sign or community vital signs, bringing that information into the electronic health record and trying to figure out how we might be able to operationalize using that to improve care and health. So that's another thing that we're embarking on with OCHIN and the IT experts there, is how do we identify, first of all, how do we identify those social determinants that are most impactful on outcomes, and then how do we bring that into the primary care setting in a way that can be useful? One of the things that we've worked on is you can ask individual patients that information, which is helpful, but maybe tedious and time consuming, and lots of those boxes end up empty in your electronic health record. You can also then take the patient address and say, based on where this patient lives, we know all this stuff about their community, and that's the community vital sign. I think we probably need a mix of both, but the community vital signs technologically we could do tomorrow. That data is available in public health data sets. We know the patient address, bring it together. With that vital sign, you might be able to immediately say that patient's going to need a 45-minute visit just based on having a community vital sign that's really high or low or however. Wow, the other thing about that is we could build in our electronic health record ways to refer those folks to social services and get them connected. So we're working with that a little bit too. I can go in and I can say, consult cardiology, consult psychiatry, consult the nutritionist. I can't go in and say, consult to the, community mental health or the elder care or the YMCA, I don't know if you guys have YMCAs here, but the some wellness center, physical wellness educational center. And so just realizing that those referrals for our patients are as important or more important than seeing a subspecialist in the medical field. The other thing, again, just the concept that I think is really valuable that we're trying to think better about is the patient is at the center. The patient really, I think, interacts with, in our case, their insurer, so Medicaid, and the patient have a relationship. The patient has a relationship with their health home or their medical home. They've got relationships in many cases with social services, sometimes even with public health services. They've got relationships with educational services. If their kids are in school, if they're adults, maybe they're in a job training program. And all those programs, the patient has a relationship with them. But we can improve patient-centered data exchange with information technology. Certainly the patient is still at the center, and that's my son there. And then we also now have the ability around the patient to share that information and do a better job of coordinating. So how do we do that, and how do we ensure privacy and security, et cetera? But we really have the ability to do that, and so we're trying to think strategically and within our organization, building as much of that health information exchange as we can. So you might not want to believe anything I said, because as you know, I come from the US, which ranks last among the developed nations in quality of healthcare, spends twice as much. Australia doing much better in overall ranking of number 4, whereas the US is dead last at number 11. You're spending a lot less money, so you might even be able to convince your policymakers and legislators to spend a little bit more on primary care, whereas we're up here now over $9,000 per person per year. So you might not necessarily want to believe what I have to say, but I was hoping if I could get this to play, I was hoping you might want to listen to an Australian from the
Well, that
past.
was, we always have to think about these things in context. And Australia was quite well off in those days. They weren't as fussed about being overexpended wherever you look. They were in fact looking to improve services and thinking of ways to provide services. It's a whole different kind of environment to the one that exists today. So I found that all very great fun. Being able to dream up a better way to do something and going and discussing it with the politicians, and most times finding a ready response. It was a Liberal government in New South Wales at the time that I was talking about. And the minister there was Harry Jager, and if I said to him, look, I think you should do this, that, the other, he'd be interested. And I remember once suggesting to him in the geriatric field that he should come with me to Victoria, where they had some sort of early beginnings of geriatric assessment and rehabilitation and stuff like that. So I think you should come and have a look. And he happily came along and had a look, and he liked the idea. So it was so different nowadays, it seems to me anyway. The main push is how to do things more efficiently, to make cut costs, yeah, and make sure that you're following guidelines and all that sort of stuff. Well, I understand that language as well, but at my time that wasn't the language. Well, just to illustrate what a ready response one could get from the politicians. Canberra gets a lot of fog in winter. And every now and then when there's a heavy fog, the planes won't take off. So I remember sitting in the airport here for a few hours one morning, waiting for my plane to take off. And I thought, oh well, I'll fill in the time writing a cabinet submission. And I wrote a submission asking for, not much, $1 million a year, that's all, for health services, research and planning. And I took it back to the office and asked them to tidy it up and make it look like a proper cabinet submission. And we went through just like that. No argument, nothing. That was in about 2 weeks. So I can't imagine that happening. And you can imagine the sort of thrill one could get in that sort of situation.
Absolutely, yeah.
So that's what Dr. Sid Sachs told me in 1997 when I was here interviewing him. So thought maybe that time has arrived again. You can do some innovative thinking and get some folks out to look at some patient-centered medical homes and maybe get $1 million, or maybe even in today's day and age, $100 million to transform care. Oh, and then there was one more that it's a bit shorter, but I thought it was useful because I'm sure it still resonates today.
The 1970s.
Oh, that's all given away in this great rush to economic rationalism, shifting the blame from costs anyway for one level of government to another. See, this way with private practice in the clinic, the Commonwealth government is paying through Medicare, whereas with that salary doctors,
It's hard to hear.
country government is paying.
Anyway, so this was
So that's changed the whole complexion of it. I like it.
that was him talking about, again, I think the struggle's still passing the buck from the states to the federal government, back to the states, and we all, I think, that theme continues to play out over and over. But one of the questions reminded me of too was, so my graduate work, when I left the US and said, gosh, I've got to find out what the rest of the world's doing because they've got it figured out better than we do, that led me to Australia, led me to Dr. Sachs and a number of other folks here who were in your government during the Gough-Whitlam era and the original architects of Medibank, which became Medicare ultimately, and the community health program, the health services research. And then I looked at a similar program that was developed after the Kennedy assassination in the US, and Johnson created what was called the War on Poverty, and created an office called the Office for Economic Opportunity, and community health programs were born there, and we still have a federal agency and a number of what we call federally qualified health centers. Well, Jack Geiger, who is kind of seen as one of the grandfathers of community health in the US, and Sidney Sachs here in Australia, had both worked in South Africa under and with Sidney and Emily Kark, who developed the concept of community-oriented primary care in the 1940s. So now is the time and the window for this old idea, it's not a new idea, but for this old idea, I think, to be realized and revitalized. So it's really exciting to think about, what we can do with the 21st century networks that we have now and the information that we have. So thank you again, and acknowledging all of my funders.